Today I want to share with you a standard 2D echocardiography exam. I will try to show you what to focus at, how to interpret the single planes, the views, and how to do the basic measurements. We will examine a 50-year-old healthy female. She's an active long-distance runner, has no obvious signs of heart failure or similar, but she's complaining of some palpitations, mainly at rest. For this purpose, I recorded the exam in an anonymized fashion. I will show you the analysis on the GE Echo Pac software only version, which you see here on this platform. Here, this is the recording that we will look at. When I open it, you see first some demographics of our demo patient. I have entered height and weight of the patient, and we have also measured blood pressure. On the right side, you see the single recorded views, and I will start with the first clip here, which is the parasternal long axis view. Now please notice that we have recorded several heartbeats in a row, so not only one. You might also record only one good heartbeat. This longer cycle here starts with a ventricular premature beat with the extrasystole. And I can tell you in this woman on the ECG, this looked like outflow tract extrasystole, which is a common benign variant of ventricular premature beats. Now for the analysis, I will focus on the last cycle, and this can be just fixed here in the Cineloop menu, where I click on the last cycle, and now we will only see the last cycle of this recording. We will also do this in some of the following clips. Now what you see here is a very nice and good view on a good parasternal long axis view of the left ventricle. We have a good echo quality. We can clearly clearly identify the different cardiac chambers. The left ventricle, here a part of the right ventricle, actually that's typically a part of the right ventricular outflow tract. In between the anterior septum with a basal and a mid segment. The apical segments are not seen here in this image, but actually in the parasternal long axis image we really don't have to see the apex. The mitral valve should be in the middle of this plane with the anterior mitral leaflet and the posterior mitral leaflet, and then this is obviously the left atrium, which can be measured here in an anterior-posterior direction. Then we have the left ventricular outflow tract. Please note the anatomy that one part, the anterior part of the left ventricular outflow tract, is the interventricular septum, but the posterior part is built by the anterior mitral leaflet. So the anterior mitral leaflet is a part of the left ventricular outflow tract, and it directly attaches or ends at the level of the aortic cusps here. This is the aortic valve with two cusps visible, and then we see a little bit of the ascending aorta. Now this is the anterior septum, and the wall here is nowadays called the inferolateral wall, again with a basal and a mid segment, and the apical segment not really visible here in this recording. So the inferolateral wall, formerly we used to call this the posterior wall. Behind that there is a strong reflex, strong ultrasound reflex. This is the pericardium, and you might notice that during systole there appears a small cavity here behind, which is actually part of the pericardium, and there is a very, very little bit of physiologic pericardial fluid here, which again is only visible here in systole. Now, behind the left atrium, you always should also look what are the structures behind the left atrium, and you might see here not very clearly a round echolucent structure. Actually, this is part of the descending aorta. There should be only one aorta visible here. Sometimes you see another quite large appearing structure which looks like a vessel here in between the left atrium and the left ventricular cavity. That can be an enlarged coronary sinus, but that is a special pathology. So there should be only the descending aorta visible here. And if you do parasternal recordings, always make sure that there are also some 1 or 2 centimeters behind the left ventricle within the image. Now this with 15 centimeters depth, I could have reduced that maybe a little bit to 13 or even 12 centimeters. But there should be a little bit more space visible so that you see and can identify pathologies here. Now, when we want to do the measurements, we will stop the image, and then we do the measurements, typically the diameters of the left ventricle and left atrium in end diastole and end systole. So the first question that comes up is how to define end systole and end diastole in this clip here. Now we have the ECG down here, and you see with the red dot here the current image. So this is what you currently see here. You also see how the system has triggered the ECG. Here at the maximum QRS width, it starts and it ends at the same time. So there is a quite good and reliable trigger here. And diastole, as you may know, can be well defined by the QRS complex. So at the time of the QRS complex, or sometimes depending on the width of the QRS complex at the beginning, at the onset of the QRS width, this is what we define typically as end diastole. Another way to identify end diastole is to look at the valves, and that is actually the preferred way in echocardiography. So here we have the mitral valve completely open. I can also go through this clip frame by frame on the right hand side. I can use these arrows here, and if I go back in the direction of the P wave, you see here that the mitral valve is a little bit closed, not completely. This is obviously the P valve, and with atrial contraction there is a second opening of the mitral valve, and then if I continue frame by frame, it is open, and at the time of the QRS it begins to close. So now it's starting to close. And end diastole is the single frame where the mitral valve is has maximal opening and before it starts to close. Closure of the mitral valve is already the start of the pressure build up in the left ventricle and is a part of systole. So I would define this as the end diastolic image, and this corresponds well to a frame very early in the QRS. However, I start my measurements in the left atrium, and for the left atrium we need the maximum diameter, and that is during left ventricular systole, which corresponds to atrial diastole, so the maximum atrial filling. For that purpose I continue to go frame by frame to the right side in the cycle, so later in the cycle. And now I have to define end systole. Some say end systole is the end of the T wave. Now this is generally usually true, but end systole cannot be reliably identified by the T-wave or by any ECG criterion. The best way to identify end systole is again to look at the valves. And now here during left ventricular contraction, obviously the mitral valve is closed and the left ventricle is ejecting blood into the aorta. If you go on frame by frame, you will notice that at some time here now the aortic valve, I go back, is open and it's closing, and now the mitral valve starts to open. So a good definition of end systole is the frame before the mitral valve starts to open. And this is just briefly after the aortic valve starts to close. So the last frame before the mitral valve opens is end systole. For the measurement, we go to the measure menu on the right side here. And normally the measure menu starts here with the generic measurements, where you can use a caliper just to do an undefined measurement, but then you have not told the system that this is the left atrium. So it's better to go to a dedicated measurement, and this can be found here in dimension, under dimensions. And here we have the left atrial diameter. So we would activate. Now we measure the diameter, the parasternal diameter of the left atrium in the anterior posterior direction. Formerly we always did this by the M-mode. Nowadays we often use the 2D image for the measurements, and you should try to imagine a line, a kind of M-mode line, which is going through the left ventricular outflow tract and through the left atrium. So I would measure here from the anterior wall, and actually I go on the edge. I'm not doing a leading edge or trailing edge. I'm doing edge to edge measurements of the anterior wall to the posterior wall of the left atrium. And this gives me a diameter of 3.7 centimeters, 37 millimeters, which is within the normal range, which should be below 38 to 40 millimeters, depending on the age and size of your patient. So this was the first measurement for the left atrium. Now, the second measurement is done for the left ventricle, and this starts not in end diastole, end systole, but in end diastole. So we would have to go back to an end diastolic frame. The mitral valve is open. I just check here briefly. Now it closes, so I go back to the last frame where the mitral valve is open. And here we want to measure the left ventricular diameter from the anteroseptum to the inferolateral wall. We also would like to measure the thickness of these walls, and this is measured in a perpendicular direction, on a line perpendicular to the long axis of the left ventricle. So the long axis is from the left atrium through the valve to the virtual apex, which is not clearly seen here. That's a long axis, and in a perpendicular direction we measure the dimension of the left ventricle. I also do this nowadays almost always in a 2D image. You might use the M-mode, but there are some pitfalls for the M-mode, and this is typically that it is quite difficult to have the M-mode line in a real good perpendicular direction. In this view, I would again go to measure, and we have here the measurements for the interventricular septum. I could do this in an automated fashion using the artificial intelligence of the system, but for the purpose here of this video I have deactivated the auto measurements and I will do this manually. So this is the first measurement for the interventricular septum in a diastolic, in the diastolic image. That's what the D stands for. And as you will see, when I finish the first measurement, the system automatically moves to the next measurement here, so that we can do this in a systematic fashion. So again, I'm doing typically edge-to-edge measurements. This is here the interventricular septum, and then we have moved to the left ventricular internal dimension, the end diastolic internal dimension, and we will stay here just below, when we view from the apex, just below the tips of the mitral leaflet. Again, starting here from the edge to the edge of the left ventricle. That gives us a diameter of the septum of less than 1 centimeter, so there's clearly no hypertrophy, and we have a left ventricular internal dimension of 5 centimeters or 50 millimeters, which is also within the normal range for this woman, which is 173 centimeters tall. Now we are also measuring the thickness of the infralateral wall, formerly the posterior wall, as I learned it in my early training year. This also shows no sign of hypertrophy. And you already see another calculated value, which is an end diastolic volume calculated to 118 milliliters. Now this is calculated only from these first measurements here, according to a formula which has been derived from amount measurements in the 70s. This is the Teichholz formula. Please note that this value actually is a rough estimate. It can be used if you are sure that there is no other pathology within the ventricle, that is, that the ventricle has no regional wall motion abnormalities. But it's a very rough estimation, and it has to be checked. It is just based on a formula which has been derived from a sample of patients, and this is not what we use today as a standard. For that we would use a two-dimensional measurement or maybe even 3D echo. Now the next thing we have to measure, we have to do the same measurements in systole, in end systole. And for that purpose, so we now have to move on in the cycle. Again, as we did before, looking at the mitral valve. Valve is closed, 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 and this is still systole. Here the mitral valve is opening, so I go back, and the last frame before the mitral valve opens is end systole. Now here we now measure the interventricular septum, internal diameter, and the infralateral wall during maximum contraction. Again here, now the interventricular septum, the internal diameter. Please note on the right side how the menu is advancing automatically, and now the posterior wall. And when we have added these values, as you can see, you now get a lot of calculated values also for the end systolic volume according to the Teichholz formula, and for left ventricular mass. Left ventricular mass is also here, as I have entered height and weight of our sample patient, is also calculated to the body surface area, and there are different formulas which are used here. Now again, this is mass, left ventricular mass, only based on a one-dimensional measurement, and this may not represent the true left ventricular mass if the ventricle is not symmetric. But for some purposes, particularly if you study patients with hypertension who have no regional wall motion abnormalities and a symmetrically shaped ventricle, or for some larger studies, population-based studies, this can be well used to get an estimate on left ventricular mass. But be careful, it's a one-dimensional measurement and you have no information what is happening, for example, at the apex here. Now these are our standard measurements. This is now end systole, and you may also, if you want to do further calculations, for example later for the aortic valve, you may also in some patients, not in everyone, but in some patients you might be interested in the diameter of the left ventricular outflow tract, which is here below the aortic valve. And this again is measured in its largest diameter, which is typically end systole, in an anterior posterior direction. Formerly I was trained to measure the left ventricular outflow tract, well, we said 1 centimeter below the aortic valve, so I would have measured here. But nowadays it's now generally recommended to stay closer to the valve, and so I will measure like this here, which gives me a quite small left ventricular outflow tract. I did this now in a parasternal long axis image, which I have not optimized for the left ventricular outflow tract. I can just recommend, if you need a true dimension of the left ventricular outflow tract, optimize your image and do the measurements in a separate clip or image optimized for the left ventricular outflow tract. There's always a tendency to underestimate the diameter and then the calculated area of the left ventricular outflow tract, and there is also there are good reasons to do this in 2 dimensions, but that's another issue. But just if you're interested, this is the left ventricular outflow tract. You might also look at the ascending aorta. We don't see much of the ascending aorta. This would be measured here in that direction. The aortic sinus can be measured here. Aortic arch has to be examined from another view. So these are the basic measurements in the parasternal long axis view. In the parasternal long axis, always also look at the right ventricle. You want to check whether the right ventricle is dilated. So that's the first clue whether there is a problem in the right ventricle with dilation or hypertrophy. So what is the diameter here of, this is actually the right ventricular outflow tract, as I said, but you can measure here the RVOT diameter, and again I do this in a little bit adapted anterior posterior direction, and in this lady the diameter is below 3 centimeters, and that is a normal value. So as soon as it enlarges above 3 centimeters, 30 millimeters, you should get the suspicion that there is some problem in the right ventricle. What you also should look at is the wall thickness of the right ventricle. This seems to be very thin here, and if you would ask me how thick is the right ventricular wall, I would tell you, well, it's very hard to measure. I almost cannot measure the thickness, and that's a good sign actually. As soon as the right ventricular wall gets so thick that you can clearly measure the thickness, so that's above 5 millimeters typically, this is a sign of right ventricular hypertrophy, typically due to chronic pressure overload. So here in this case, normal diameter and a thin wall, that looks pretty good. An additional comment to the valves here in the parasternal long axis view. You see the cusps of the aortic valve. You see 2 cusps. It's very difficult to decide which cusp you see. We will come back to that later. But as you can see, even without any color Doppler, The cusps look quite thin and homogeneous, and there is no evidence for an increased echo reflex, so no evidence for calcification or some other pathology. The same holds true for the mitral valve. The mitral valve, you also see here the chordae, tendinae, so the chordae which prevent that the mitral leaflets prolapse into the left atrium. You might even notice here that there are different types of chordae. There are the primary and the secondary chordae. The primary chordae attaching more at the rim of the leaflet, and then there are chordae attaching more to the middle of the leaflet. And the chordae end here in a papillary muscle, which is hardly seen in this example. Now let's move on. I just want to show you here, this is a traditional way how to measure left atrial diameters. This is the M-mode. The M-mode now here is placed across the aortic valve or the left ventricular outflow tract, and we try to capture here the largest diameter of the left atrium. As I said already, I typically do the measurements in the 2D images nowadays, but some echo labs still stick to the traditional M-mode if they get a good recording. The M-mode recording, so we see only one line here. So when you have the right ventricle in the small 2D image here above here, then this would correspond to this area here. Then we have part of the outflow tract. This is this structure. You see a little bit a part of the aortic cusps open and closing. And then you have the anterior wall of the left atrium, and here the left atrial cavity and its posterior wall. Of course, you can do measurements also here. We have some prepared, we have a prepared menu here, a dedicated menu for the measurements. I select left atrial and aorta. The menu now tells me, if you look at the lower border here, the lower border, that I should place the measurement on the anterior point of the aorta. Well, I do the measurements here in the M-mode as it tells me the aortic diameter. Actually, I don't use this measurement because I don't trust it very much. The M-mode is optimized for the left atrium, so now I would focus on the left atrium, again doing an edge-to-edge measurement. That is how we do the measurements, edge to edge. There are some other labs doing a leading edge to leading edge measurement. That would be a little bit more here and a little bit more anterior in the posterior way. Now I get a left atrial diameters, as you can see here, of 36 millimeters, which is about the range what I measured also previously in 2D. The problem is, obviously, it's a one-dimensional measurement, and it's not always easy to adjust the parasternal long axis so that you get a real true anterior posterior maximum diameter of the left atrium. That can be even more difficult for the left ventricle. Here we have the M-mode of the left ventricle. You see again anteriorly this is the right ventricular outflow tract. Then you see the motion of the septum. You see how it thins and becomes thicker. You can nicely see the temporal behavior of the septum in end diastole, and then during systole the maximum contraction here. And below you see a part of the mitral leaflets, the anterior mitral leaflet, as it opens and closes again, and then it is closed, and we don't really see here the first opening of the valve. Looking at the dimensions, you can of course do the left ventricular dimensions also here in the M mode, and that's the traditional view, as I told you. Again, you open the measurement menu, and now you can, for example, do this LV study. You can choose the single values in under the sub-menu dimension, starting with the interventricular septum in diastole. But you can also, here in the GE version, you have here LV study, and that directs you first to measure the anterior point of the septum in end diastole. And diastole again is marked by the QRS, so the maximum QRS, or a little bit before. So if I would do that here, actually I would end up doing the measurement here, going, that's the thickness of the septum. Then I go to the posterior wall. Now it's nowadays infralateral wall, marking the anterior point. And please note, this is a mitral valve here. This is the posterior mitral valve leaflet, or some chordae, difficult to say sometimes. But this is here the anterior point of the posterior wall, and then measuring just a little bit before the strong reflex by the pericardium. So this is the diameter of the posterior wall. Now the next measurement is ansystole. And this is here a little bit tricky. You see in this lady, the septum is thickening and the posterior wall is thickening. It's already getting a little bit difficult to identify the borders of the posterior wall. And you also notice that the septum has its maximum inward motion at a time when the anterior mitral leaflet already obviously is maximum, has maximal opening. So from what I told you before, this cannot be ansystole here. Ansystole is this point here, which is at the same time when the posterior wall has its maximum inward motion. And what we see here is some kind of post-systolic septal motion. Post-systolic septal motion, if you look that up or if you read about it, it can be a sign of ischemia, but it's also normal in healthy persons to some degree. So it's not the maximum inward motion of the septum which defines here ansystole, it's more the maximum inward septum of the posterior wall. And that is a physiologic post-systolic septal motion. So when I measure here, and systole is probably somewhere here, and these are the diameters, and this is what we get as a result. You may scroll back in the video and compare those values to the values that I obtained with 2D measurements, and you might notice that there are some differences, which are mainly due to the different methodology of measurement. The M mode, however, is very good, as you notice here, to define the timing and to look at the time events during the cardiac cycle. And you see a lot of interesting behavior also in pathology, in particular of the interventricular septum. So it's always worth to look at the M mode and to compare the motion of the septum and the posterior wall, and to learn from that with respect to a normal and pathologic septal motion. Now we move on, and one thing that we haven't done yet is to look at the blood flow. So we typically, in the parasternal long axis view, also activate the color Doppler. Although, as you know, the color Doppler depicts mainly the blood flow in direction of the ultrasound beam. Obviously, the blood is flowing mainly perpendicular here from the left atrium to the left ventricle, and from the left ventricle to the ascending aorta. So you might think that it's not useful to do the color Doppler, but you want to look for valvular regurgitations mainly that creates turbulence of flow, and turbulence of flow can also be well visualized in that direction here. And you might notice there is a quite small, very small amount of turbulence here at some time at one cycle in the mitral valve, so it's a very tiny trace mitral regurgitation which can be picked up here. But in general, this looks pretty normal here. There is no regurgitation jet across the aortic valve, and a very tiny one for the mitral valve. If you do the color Doppler during the exam, I would recommend to tilt always the probe in the other axis, so more to the right and left, so to scan a little bit for regurgitation at the extreme borders at the side of the valves. When we have done this, we turn the probe about 90 degrees and we take a look at the short axis. Again, here we have a longer sequence, and so you notice a ventricular premature beat. That's the reason for the exam here. But here I focus again on the last cardiac cycle. The last cardiac cycle always checks the ECG, has no premature beats, so that's a normal contraction. That should be the normal situation without any disturbance by arrhythmias. And you can nicely see here the short axis view partly imaged the papillary muscles, so that's the posterior medial papillary muscles, and that's the anterolateral papillary muscle. You see the circumference of the left ventricle with the anteroseptum here and the inferolateral wall here. So we have lateral and anterior, this is inferior, and this is inferoseptal wall. Always look at the thickening in the short axis view, because you look now, you can focus on radial thickening, and it's sometimes easier in the parasternal short axis view to detect regional wall motion abnormalities than in the apical views. So don't forget to look at the short axis views. And of course, this is a level of the papillary muscle. You have to tilt the probe in the long axis direction to pick up a little bit more of the basal left ventricle, and you should also try to image the apex. When I go back to the papillary muscle level, please also note this is anterior, this is the back of the patient, so here comes the spine, this is posterior, this is inferior. We call this now the inferolateral segment, however, and this is the inferior segment, this is part of the liver here. Again, here part of the right ventricle, anteroseptum, which is part of the right ventricular outflow tract, typically if you go a little bit higher up, and this is a free wall of the left ventricle. I told you we have two papillary muscles typically, the posterior medial and the anterolateral. However, this is anterior, this is posterior. Please note that if you draw a line here, a horizontal line, that actually both papillary muscles are more on the posterior half of the ventricle. So the anterolateral is not truly anterior, it's still quite posterior in the left ventricle, closer to the spine than to the anterior wall of the thorax. What is the reason for that? Why are the papillary muscles here in the posterior half of the left ventricle? Well, you might get an idea if you go back to the parasternal long axis view. Focus again on the last cycle. So this is an anterior mitral leaflet. Here's a papillary muscle, one of the papillary muscles. I don't know exactly which one actually, or it's just in between. But what's important is that the papillary muscles are important to drag away the anterior leaflet more to the posterior wall. If there would be one papillary muscle up here in the anterior wall, then the mitral leaflet might be dragged more to the outflow tract and might cause obstruction of the outflow tract, which we now only see in a specific pathology, the hypertrophic obstructive cardiomyopathy. But in the normal ventricle, the posterior placed papillary muscles prevent the obstruction by the anterior mitral leaflet of the outflow tract. So I think that's the anatomic reasons why, if we look at the short axis views, both papillary muscles are more posterior than anterior. Now from this view, if we tilt a little bit towards the cranial direction, our image plane, we get now a short axis view of the basal segments, and here we also have some view of the mitral valve, and that's the kind of fisheye view what we see. So this is like not fisheye, fish mouse appearance of the mitral valve, with parts of the anterior leaflet hardly visualized here and parts of the posterior leaflet. And above here, that would be the direction of the outflow tract. And if I go a little bit higher up, I come closer to the aortic valve and the outflow tract. And that's another very interesting short axis view, the level of the aortic valve. I try to, again, focus on the last cycle here, and we'll stop the image here. Let's go back or a little bit back and forth, frame by frame. So if I stop here, you see in the ECG, my marker is somewhere after the T wave, so I'm about end systole here, and the aortic valve, or I'm in early diastole, and the aortic valve is closed. This here, well, if you look at the Parasternal long axis view, you know this is right ventricular outflow tract, aortic valve, left atrium, right atrium, and if this runs, this obviously is the tricuspid valve, or are two leaflets of the tricuspid valve, right atrium, so this must be the interatrial septum here. And if you would put color on here, you might see an ASD, an atrial septal defect. So this is the interatrial septum. And if you focus on the aortic valve, again I stop it, you see that there are three cusps. You have here the rim, it's like, this is like a star configuration, the Mercedes star as we typically call it, at least in Germany, where the Mercedes cars are produced. We have three cusps, one here, and one here. And how are these cusps identified? Well, this is the right ventricle. This is the right ventricular outflow tract. And these cusps are related to the coronary arteries. And if you know that this is the right ventricle, so this cusp is the right coronary cusp. This goes to the atrium. This is the interventricular septum. And in the direction of the, interatrial septum, in the direction of the interatrial septum, there is no coronary artery. So this is the acoronary cusp. No coronary artery, acoronary cusp. Here on the right, in the right of the image, you might sometimes see the left main stem. And if this is the right coronary cusp, then this is the left coronary cusp. So we can clearly identify right coronary cusp, left coronary cusp, acoronary cusp. Okay. We have identified the tricuspid valve, the aortic valve with its cusps. And if we let the image run, you notice that there is also something moving here on the right side. And actually, this is a pulmonary valve. It's not very optimized here for the pulmonary artery. We will take a look at the next image. Not very clear. Yeah, I go back here. I go to the first cycle. Maybe here in this cycle, well, you might appreciate that this is a part of the pulmonary valve, and that would be the proximal part of the pulmonary artery below here, which is not very well visualized here. But as you all also notice, the valves, the aortic valve and the pulmonary and tricuspid valve, they're not lying in one plane. They are perpendicular to each other. Okay, let's have a look at the next one here. Now, also here, I activated the color Doppler because you might see some turbulence if you have aortic regurgitation, which is not the case here in this image. You might, in this parasternal short axis view, be able to locate the origin of the aortic regurgitation very precisely to the cusps, whether it's more to the left coronary cusp or more to the acoronary cusp here. So again, a color Doppler, very important also in this view. Here I activated the color Doppler more across the pulmonary valve. You see the outflow here of the pulmonary valve, and even if you're not able to visualize the pulmonary valve completely, you will be able to activate the Doppler. And here I activated a pulsed wave Doppler sample and put it across on the level of the pulmonary valve. So you have the outflow across the pulmonary valve, and you may exclude by that there is any significant pulmonary stenosis. Well, actually, to exclude pulmonary stenosis, or maybe also a stenosis in the main trunk of the pulmonary artery, you would also do a continuous wave Doppler recording. From the pulmonary valve, we can also move the color to the tricuspid valve and look for tricuspid regurgitation here. There is just popping up a little bit some turbulence, but there is no true tricuspid regurgitation visualized here. And you might also try to put a continuous wave Doppler across the tricuspid valve here to measure the regurgitant velocity for the estimation of right ventricular systolic pressure, but we will come back to that later, and we will try to do this in the apical views. So from the parasternal views, I moved now to the apical window, and I tend to start with the apical four-chamber view. I know that some people recommend to start from the apical long axis view because that gives you a better idea of the apex and to optimize for shortening. But the apical four-chamber view is, in my experience, more easier to image because you have a better positioning or an easier positioning between the ribs for the apical four-chamber view of your ultrasound transducer. And that's maybe one of the reasons why I like to start to get a first view on the apical four-chamber view. Again, I focus here, I have a long sequence, I focus on 1 cardiac cycles. I may increase a little bit the gain here just to demonstrate for you and that you better can identify the left ventricular walls. The apical four-chamber view, I stop the image here. Apical four-chamber view is called four-chamber because we have the left ventricle, part of the right ventricle, more the inflow part of the right ventricle, of course the right atrium and the left atrium, 4 chambers. You have to know what kind of segments you look at. This is part of this is more the inferior septum. This is the lateral wall. We have, again, we see here the mitral valve, more or less in the middle, or really in the middle is the septum and the interventricular septum, the interatrial septum. Then we focus on the mitral valve with again an anterior leaflet and a part of the posterior leaflet. You might appreciate the papillary muscles, the chordae, different chordae at the rim of the leaflets and more attaching to the middle of the leaflets. You can appreciate the left atrial size. You may be able to measure the left atrial volume here or area. And on the right side, you can take a look at you should take a look at the tricuspid leaflets and the right atrium. We have here the interatrial septum. There seems to be an opening in the interatrial septum. This is typically the thinnest part of the interatrial septum, which is the so-called foramen ovale. Okay, if we look at the contraction of the left ventricle, there seems to be an inward contraction and thickening in all segments. However, thickening is often very difficult to detect from the apical windows, and particularly in the lateral segments. So you really have to take care that you have the best possible image quality. And what you also notice, the ventricle is not only thickening inwards in the radial inward motion, it's also moving with along the long axis. So the level of the mitral valve here, or the tricuspid valve, is not on a constant level, but it's moving up and down, and that is the very important long axis contraction or long axis function of the left ventricle. I will come back later to the RV function analysis. Let's have a look first at the anatomy of the other apical views. Now this is the apical four-chamber view, where I typically start my apical exam. If you now turn the probe 60 degrees counterclockwise, you first will end up in the apical two-chamber view. Two chambers, the left ventricle and the left atrium. The left ventricular two-chamber view is characterized by some distinct features. Now we see the anterior wall of the left ventricle, and on the other side now the inferior wall of the left ventricle. You see parts of the mitral valve. It's often you don't see the complete opening here, depending on how you focus here, but you should see the true apex of the left ventricle. And in the apical two-chamber view, the left ventricle typically is a little bit banana-shaped, and there is the anterior wall is a little bit convex, and you should try to optimize here for the left ventricular apex. What you typically should see at the level of the left atrium is on the right side, if it's large enough and if the image quality is good enough, the left atrial appendage, or you might, well, at least guess that the left atrial appendage is here. It's very clearly visible in this case here. And on the other side, a round structure, which is the ostium of the coronary sinus. So the ostium of the coronary sinus and the left atrial appendage and the left ventricle, the true apex, characterize the apical two-chamber view. If we further turn our probe counterclockwise 60 degrees, we end up in the apical three-chamber view. The apical three-chamber view, also called the apical long axis, is actually the same view, or you see the same structures, almost the same structures as you see it in the parasternal long axis view. So this view, you can turn it, tilt it in the image, and then you end up with a kind of parasternal long axis view. But here now you can appreciate the left ventricular apex. Also here you should try to optimize that you have no foreshortening. Actually, the motion here in the apex, which comes very suddenly, becomes shorter, or there is some wall coming into the image. tells me that maybe I still have some foreshortening here in this case. We have the same walls that we see in the parasternal long axis view. So this is the anterior septum, and on the other side it's the inferolateral wall. Formerly, when I was trained, we called this the posterior wall. We have the anterior mitral leaflet and the posterior mitral leaflet. We don't see the ostium of the coronary sinus. We don't see a left atrial appendage, but we see the left ventricular outflow tract, the sinus of the aorta, and a little bit a part of the ascending aorta. So this characterizes the apical long axis view. In each of these views, we should activate the color Doppler and looking across the valves for regurgitation or turbulent inflow in the presence of stenosis. And in each of these three apical views, you should always not only activate the Doppler, but then tilt a little bit the probe so that you really scan the complete valve. Here, the color Doppler is focused at the mitral valve, and you might appreciate a slight, very trace regurgitant flow a little bit during systole, which is a minimal mitral regurgitation. Also here in the apical four-chamber view, focusing at the last cycle, the Doppler shows us laminar flow, red and blue colors, and not much yellow or green colors, so not much turbulence, so there is no significant flow acceleration and no significant regurgitation in that view. From the apical four-chamber view, so this would be this one here, you might also turn the probe clockwise a little bit, and then you end up in the apical five-chamber view, where the outflow tract is now here in the middle of the image, not on the right side as in the apical long axis view, but quite the opposite on the left side of the left atrium, and we call this the apical five-chamber view. 5 chambers. Why 5 chambers? You see a little bit of the right atrium, the right ventricle, 2 chambers, left atrium, 3 chambers, left ventricle, the 4th chamber, and the 5th chamber is now not a really true chamber, but it's a left ventricular outflow tract, which is visualized here. So that's why this view is called the so-called 5-chamber view. There are not true 5 chambers, but the outflow tract counts here as a 5th chamber. So again, I activate the color Doppler also in this view, and this is nice to visualize the outflow across the aortic valve to look for aortic regurgitation. Of course, that can be done in the same manner in the apical long axis view. In the apical 4-chamber view, we typically activate the pulsed wave Doppler, for the documentation of mitral inflow. The pulsed wave Doppler has a sample volume. It measures the flow just within the sample volume indicated by these 2 small bars here, and this is positioned at the level of the mitral leaflet tips. So if I would go back here to the apical 4-chamber view, let's go frame by frame. I would position here the sample volume just at this level between the opening of the mitral leaflet tips. And that gives me the mitral inflow signal in a pulsed wave Doppler signal, where we have here the cardiac cycle, systole, and after the end of systole, the mitral inflow starts. That is the early filling wave, the E wave. And then in this patient here, we have a bradycardia. The heart rate is below 50. In this trained athletic female, we have a long time where there is no flow. That's diastolic diastasis, as it is called. And then we have a small second peak, and that is the atrial contraction. So we have an E wave and an A wave. Atrial contraction ends with the onset of systole. And due to bradycardia, there is this long period where there is no flow. So diastole here is very long, and flow is already happening in early diastole. Actually, also the atrial contraction wave is very small here. This does not indicate that atrial contraction is poor. It just indicates that there is not much flow during this period. Most of the flow has happened during early diastole, and there is not much left to fill the left ventricle, and that is why the E wave here is quite small. We can measure here the E to A ratio. So I go for the mitral valve, EA velocity, and I would now measure the maximum early inflow velocity. Please note that I tend not to measure the absolute maximum small signal, but I tend to stay within the this broader part here, which is the so-called modal velocity. So most of the blood volume flows with this with the velocities within this wide range, or in this case here, yellow range. So I don't go to the absolute maximum. I stay a little bit within here, and then I indicate the E wave. I indicate typically in this measurement also the deceleration time, how long it takes to decelerate again to zero. And then the system wants me also to indicate the maximum A wave. I also try to stay within here. And we have an EA ratio, which is quite high here with 2.6. And we have a deceleration time, which, if you look it up, it is quite short. So you might think that this is a restrictive filling pattern, which should be a pathologic situation. Well, in fact, this can also be seen in super healthy, super relaxing left ventricles. This is a pseudo-restrictive filling pattern, actually, but that is a topic for another lecture. So in this case here, this is a normal situation. This is a healthy ventricle, and most of the blood during diastole enters during the early diastolic phase. There is bradycardia, and there is a long time, much more time for filling that is needed. And most of the volume has entered during early diastole. There is a good relaxation, a good suction effect of the left ventricle, and there is only a small volume left, which enters the left ventricle after atrial contraction. And that gives rise to a small A wave. But this is where we measure E and A ratio. So after the standard measurement of the mitral inflow pattern, we might take a closer look on cardiac function by comparing the mitral inflow to the long axis function of the left ventricle. I told you, going back to the apical 4-chamber 2D image, there is a significant long axis motion of the left ventricle. So it's not only inward contraction by thickening, but there is also a shortening of the complete left ventricular cavity during myocardial contraction, and that gives rise to a displacement of the atrioventricular, of the AV plane, the atrioventricular plane, in the direction of the long axis of the ventricle. There are different approaches how to measure this. In another video I show you how to measure this by left ventricular strain analysis. An easy or a simple method to look at long axis function is to activate a kind of M mode. So to set a line across the left ventricle at the hinge points of the mitral valve leaflet. I might try to do this here. I can activate here a kind of M-mode, and I place this here at the septal hinge point and at the lateral hinge point. I did this here in this recording with a original M-mode, the one that you saw before. It's a kind of post-processing of the 2D image, but here this is a true M-mode. And what you now see here is that we pick up the motion of this atrioventricular plane, and this is picked up here. So this is the motion of the atrioventricular plane. You have this strong reflex here, and you can measure now this excursion. I have to use here a generic measurement because it's not integrated in the menu here, but you can also define your own measurement for this mitral annular plane excursion, systolic excursion, and that is a so-called MAPSE value. And you measure now from the end diastole, and I stay on the line here, up to the end systole, so the maximal inward motion, and that gives you a value of 15 millimeters for the septal hinge point here. So that's a long axis function at the septal level. And we can also do this for the lateral level. So this is here across the lateral aspect of the mitral valve. And again, I measure here, I use a generic measurement, and I measure here typically more at the lateral level, a little bit more, 16 millimeters motion in the apical direction. So this is the measurement of MAPSE. Most of you know this apical measurement for the right ventricle, the tricuspid annular systolic excursion, the TAPSE value, which is frequently used for the right ventricle in the presence of pulmonary hypertension or suspected pulmonary embolism. Another way to look at long axis function is the tissue Doppler. The tissue Doppler, you switch to tissue Doppler, you change a little bit the settings of the color Doppler, and you focus on the motion of the myocardial wall. Then you can also place a sample volume here at these hinge points. It's the point of the basal septum where the mitral leaflet attaches, and you get in a kind of in a pulsed wave Doppler spectrum, you get now the velocities of motion. Just to explain that, again, look at the ECG. This is systole here, and during systole you have a positive motion of this point towards the apex. That is the apical long axis direction. And then during diastole you have a one negative wave and a second negative wave, and that corresponds in time to the E wave and the A wave of the mitral valve, just going into the opposite direction because the ventricle is moving downwards towards during relaxation. So this is a systolic wave, this is the early diastolic wave, and this is the late diastolic wave, the atrial contraction wave, the A wave. You also notice here that there are some short-lived events between the A wave and the S wave, and that is during the isovolumic contraction period, and there is another one here during the isovolumic relaxation period. If you now measure the velocity of the E wave in the septal pulse wave Doppler, that is what we call it E prime. So then you get a E to E prime ratio, which is here approximately 9.5, which is a relatively low value, not a very low value, but it's it is not significantly elevated, and is frequently seen in healthy people. We can do the same measurement on the lateral level. So I do here now another measurement. I hope it shows up on the lateral value. Now it gives me only the E prime as 0.11. It doesn't give me the calculation because I did this already in the last one. But again, you can calculate the E to E prime for the lateral wall. Well, let's do it briefly. We repeat the measurement of the E to E of the E to A velocity. Just doing that briefly, that should give us the ratio. And here the ratio comes up for the lateral wall with 6.7, which is a clearly low value, indicating that that the left ventricle has a good relaxation property and that the left end diastolic pressure is not elevated. So for the aortic valve, I typically use the apical 5-chamber view. You may also use the apical long axis view to image the outflow tract and the aortic valve. Please note that if you use the apical 5-chamber view, don't just tilt the probe from the 4-chamber view, but rotate it slightly in the clockwise direction. Now you can place a pulse wave Doppler sample. You may look first at the color Doppler, look for turbulence, but then you place a pulse wave Doppler sample at the level of the outflow tract and later activate the continuous wave Doppler. Unfortunately, I noticed that in this particular patient I have forgotten to store the aortic Doppler, so I will explain that to you in another healthy athlete. Here I have the pulse wave Doppler signal in the left ventricular outflow tract, and you see the Doppler spectrum. So notice this is the zero line. Everything that is below the zero line is flowing away from the transducer, away from the apex, and obviously from the left ventricle into the aorta. You have a typical pulsed wave Doppler spectrum with a modal outer velocity. So you have this bright spectrum at the outer border, defining the outer border of this flow velocity spectrum. And this is depending on the amount of blood cells that are moving with the same velocity. They are accelerating during systole, they reach a certain peak, and then this velocity is decelerating again. There are not many blood cells during systole which are flowing with a low velocity. So this is why this inner part of this Doppler spectrum remains very dark or black. If you want to measure here, you have this is the outflow tract, and you might then look at the left ventricular outflow tract tracing. So I trace the spectrum here, go back to 0, I indicate the heart rate, and if you have measured the left ventricular outflow tract diameter before, which obviously has been done here in this case, you can get estimates on the left ventricular stroke volume and the cardiac output, in this case here at rest. Because if you do the contouring here, you integrate all velocities during systole, and if you know the area of the outflow tract where the blood flows through, you can calculate stroke volume. Having done this, the most important measurement in the routine setting is to place a continuous wave Doppler across the aortic valve. Why a continuous wave? With a continuous wave Doppler you measure all the velocities across the whole line. With a pulse wave you measure only where your sample volume is. With a continuous wave you measure all across the line, and if you along this way, if you have a maximum velocity which is like here below 1.5 meters per second, which is close to 1 meters per second. So you have normal velocities. You know pretty sure that there is no pathologic flow acceleration on this way. So no significant hemodynamic stenosis of, for example, here the aortic valve. You may also, like before, do the tracing. This is useful in particular in pathology with aortic stenosis. And let's see what comes out here. Yeah, if we do the calculation here, this would be a calculation of the aortic valve area by the continuity equation. And that would give a very large aortic valve area of more than 4 square centimeters, which is absolutely normal. And of course, there is no stenosis present here. So coming back to Our Lady, here I focused on the right ventricle. This is from the apical 4-chamber view. You move the probe and tilt it a little bit. You move it to more laterally and tilt it a little bit to the right ventricle, and then you might obtain such a focused right ventricular view. Here you have a nice view on the tricuspid valve. You see most of the wall, of the free wall of the right ventricle. You might measure here the long axis function of the free wall of the right ventricle, the so-called TAPSE value, tricuspid annular systolic excursion. So a lot of important information. I tried here to put a continuous wave Doppler probe across the tricuspid valve. In the previous color Doppler, you saw that there was not any significant regurgitation across the valve, and that also is seen here in the Doppler spectrum. There is some signal here during systole, and here also. We can move on frame by frame also. So there is some signal, but it's very hard to detect where this ends, and the velocities where it's clearly seen are quite low. From the regurgitant velocity, you would be able to measure the regurgitant pressure drop, pressure difference across the tricuspid valve. So let's just as an example, let's just measure here. Well, I estimate that maybe here could be the end of the signal. There is a regurgitant velocity of 2.4 meters per second. So that's the velocity from the right ventricle to the right atrium. And this velocity is dependent on the pressure difference. And this calculates, after a modified and simplified Bernoulli equation, the 2.4 meters per second calculate to a pressure difference of roughly 23 millimeters of mercury. And this pressure difference, you would add the right atrial pressure, which is probably relatively low here. So add a few millimeters of mercury to 23. So roundabout we get 25 millimeters of mercury, and that would equal to the maximum systolic pressure in the pulmonary artery. So we have a systolic pressure in the pulmonary artery below 30 millimeters of mercury, and this effectively rules out significant pulmonary hypertension. From this subcostal view, we call this the subcostal 4-chamber view. You can tilt your probe towards the liver and the cava inferior, and then you look at the diameter of the left inferior vena cava to estimate the right atrial filling pressure. You should take a look whether it's chronically dilated, whether it's collapsing, and of course you can put a Doppler sample volume inside a liver vein. There is typically one liver vein which enters the cava inferior in a way that it's ideal for a Doppler measurement. And here you see there is a biphasic inflow at systole, but also during early diastole in this healthy woman. If you have a less healthy person with right ventricular hypertension or with more significant tricuspid regurgitation, then you would notice a very significant systolic backflow due to the high pressure, due to the high afterload, and this can be very nicely picked up by this liver vein Doppler, which should be part of every exam where you see a clear pathology on the right side. From the subcostal four-chamber view, as you see it here, you can very elegantly image the interatrial septum. You can put a color Doppler across the septum here. I'm sorry I haven't an example here from this exam, but this would give you an ideal view on atrial septal defects, which where the flow would go from the left atrium to the right atrium just in the direction of the transducer here. But you can also subcostally tilt the probe and try to obtain short axis views as seen here. Of course, you have to then rearrange the segments of the left ventricle in your mind. And if you then tilt more to the cranial direction, you might get an ideal view on the right ventricular outflow tract, ideal for Doppler and for judgment whether there is significant pathology. Of course, this is also a good place for placing a Doppler signal, either by pulsed wave or by continuous wave imaging. Well, if you want to measure ejection fraction and if you want to learn about the size of the left ventricle, you have to do the contouring, and you cannot estimate this only visually. Although we see here that the the ejection fraction looks pretty normal. If you need a quantitative number, we have to do some contouring. Before I had to do this manually, I will show you the auto EF method, which is based on artificial intelligence. And if you choose for the auto EF, in this case, the device already detects that this is an apical four-chamber view. This is automatically detected, and already some contours are drawn. However, as you know from this image, the apex seems to be a little bit foreshortened. That's why I make here some corrections, maybe not so much. And when I'm happy with the contouring, we have the septum and the lateral wall, I press on process. The image or the loop is tracked throughout the loop, and we obtain an ejection fraction of 56%, which is in the lower range, but quite typical for athletic persons at rest. They don't have a high ejection fraction. They are very happy with a low normal ejection fraction. And you also see the value for the end diastolic and end systolic volumes, 102 and 45 milliliters. You can stick to the monoplane ejection fraction measurement, but if you want to be more precise, you add a second plane, and this is typically the apical four-chamber view, as I have it here. Again, I do some corrections for the wall detection. I press on process, and now the second plane is analyzed and added, and we obtain ejection fraction here in the two-chamber view. It's automatically identified of 57%, and an end-diastolic volume of 180 milliliters. The biplane ejection fraction for both the apical four-chamber and two-chamber view is 56%. You can calculate, because you know the stroke volume and the heart rate, you can calculate a cardiac output, which is calculated here to a quite low value at rest. And you have the heart rate here. Of course, then you see the end diastolic and end systolic values in a biplane fashion for 110 milliliters and 49 milliliters, which is in the normal range. So we went through a complete 2D echo exam in detail. I hope you enjoyed it and you learned a bit. I tried to show you what to look at, how to measure a few things. Of course, there's much more to learn, and we just looked at a normal, healthy athlete. Of course, there are a lot of pathologies which I will try to explain in further videos. Thank you very much for your attention.